Bismillah ar-Rahman ar-Rahim. Ischemic heart disease, part 2. Acute myocardial infarction. Acute myocardial infarction, or what is also known as a heart attack, is defined by having necrosis in the heart muscle due to ischemia. This is a significant cause of death worldwide. As you can see in this picture, there's an atherosclerotic plaque inside one of the coronary arteries, and this atherosclerotic plaque is complicated by a superimposed blood clot or thrombus. This acute occlusion of the coronary artery will lead to ischemia of the downstream tissues that are supplied by that particular coronary vessel. So there will be a damage or necrosis in the heart muscle that is supplied by that artery. This is the definition of acute myocardial infarction. Clinical features of acute myocardial infarction encompass certain classical signs and symptoms. The most significant and the most distinguishing one is having the ischemic cardiac pain, which is usually described by patients as a severe crushing substernal chest pain that radiates to the neck, jaw, epigastrium, or the left arm. Other common symptoms include dizziness and sweating, rapid and weak pulses, both of which are related to activation of the sympathetic system. Dyspnea, which means shortness of breath. This is especially common if there's an associated pulmonary congestion and edema. Nausea happens especially in cases of posterior myocardial infarcts because of activation of the vagus nerve. Cardiogenic shock occurs when there is massive myocardial infarcts, and we mean by the word massive that a large portion or volume of the heart is affected or damaged. So when there is more than 40% of the left ventricle having the myocardial infarct, there will be loss of the pumping action of the heart, and this will lead to cardiogenic shock. In a variable percentage of patients, though, there will be no classical or no typical symptoms. We call this condition silent infarct. So the word silent infarct describes a patient that is having acute myocardial infarction without the classical signs and symptoms of acute cardiac ischemia. Now, a variable percentage of patients might have this silent infarct. And this kind of myocardial infarction can only be confirmed using ECG examination and lab workup. Patients who are particularly prone to develop silent infarcts are diabetics and elderly. Regarding the cause of acute myocardial infarction, you will see that most of the cases are related to acute occlusions of the coronary arteries. Now, occlusion of the left anterior descending coronary artery was found to be the cause in up to 50% of all cases. This diagram shows us how myocardial infarction evolutes. On the left side, you have here, as an example, acute coronary occlusion in the left anterior descending artery. Now, the part of the cardiac tissues that are directly supplied by that artery are now at risk of ischemia. We call this area at risk of ischemia the zone of perfusion. Now, if we take a cross-section of the myocardium at the area or the zone of perfusion, you will see that the occluded coronary artery lies just beneath the pericardium, overlying the myocardium. So the endocardium is the farthest part of the cardiac tissue from the blood supply. All of this area is called zone of perfusion, or what we know now as the area at risk of ischemia. Now, after some time, let's say more than 30 minutes, necrosis will start to develop. And the zone of necrosis here relates to or describes the area of the necrotic cardiac tissue. As you can see in the picture, necrosis begins just beneath the endocardium. So the first part of the cardiac tissue to show signs of necrosis would be the farthest from the coronary artery blood supply, and these are in the subendocardial areas of the myocardium. The endocardium will be spared from necrosis because it can have blood supply through diffusion from the cardiac chambers. Now, 2 hours following the infarct, the zone of necrosis would be the subendocardial myocardial muscles. Now, if this area of ischemia or the zone of perfusion is not treated, or this occlusion is not treated, over the next 24 hours, the zone of necrosis will expand until it covers all the area that was called the area at risk, or the zone of perfusion. So after 24 hours from the onset of the acute occlusion, the area at risk, or the zone of perfusion of that particular occluded coronary artery, will become all necrotic and replaced by necrosis. And so the zone of perfusion would all be replaced by a zone of necrosis. Now, evaluation of myocardial infarction is a very crucial part of the management of those patients. This is, as I said, is a major cause of morbidity and mortality worldwide. So the first part would be evaluation by clinical signs and symptoms, just like the ones we already described. Now the second part, which happens usually inside the emergency department, is having an electrocardiographic examination of the patient, or ECG test. Detection of certain ECG abnormalities is confirmatory of having acute myocardial infarction. The third step would be laboratory evaluation, using certain blood tests to detect intracellular macromolecules that will leak from the injured or damaged myocardial cells through the damaged cell membranes. Now, those intracellular cardiac molecules that leak into the circulation following cardiac damage are called cardiac enzymes or cardiac markers of MI. These include many things like myoglobin, cardiac troponins T and I, creatine kinase, especially isoform MB, which is specific for the myocardium, and lactate dehydrogenase. The best markers for acute MI were found to be cardiac troponins T and I, because they are very specific to the cardiac muscles and they stay elevated for a long period following acute myocardial infarction. The second best markers are creatine kinase isoform MB, because it's also specific for the cardiac muscles. Microscopic features of acute myocardial infarction and its repair. Now, this is not part of the diagnostic process of acute myocardial infarction. You should understand that this is only an autopsy confirmation. So, whenever someone dies because of cardiac causes, and there's a suspicion or confirmation of acute myocardial infarction, the following findings can be seen under a microscope, and these findings describe the chronological pattern and the evolution of myocardial infarction over time. Now, the first part of these microscopic features happened during the first 24 hours following the onset of the coronary occlusion, and these are mainly coagulative necrosis of the myocardial muscles. The necrosis would lead to the formation of wavy fibers. We mean by those wavy fibers, these are necrotic and wavy cardiac muscles. The necrosis will also be associated with edema, which will separate the cells from each other. The stain used here is the conventional hematoxylin and eosin stain, which uses the colors pink and blue. The second phase of the myocardial infarction evolution happens during the first 2 to 3 days following the onset of the infarct. During this period of time, a dense neutrophilic infiltrate would replace the edema and the necrotic tissue. This is because cell damage or necrosis would always be associated with inflammation, and the first part of the inflammation would be acute inflammation, and this would use neutrophils as the main recruitment. 7 to 10 days following the onset of the acute myocardial infarction, the area of the infarct is full with another type of inflammatory cells, which is the macrophages. And during this period of time, there will be complete removal of the necrotic tissue by those macrophages. And this is a different phase of inflammation that happens or develops following tissue necrosis. Within the first 14 days following the onset of myocardial infarction, and actually at the 14th day, there will be granulation tissue formation. So granulation tissue formation will peak during this period, 2 weeks following the acute myocardial infarction. The stain used in this microscopic picture is called Masson trichrome stain. It gives us blue and red colors. The blue color is for the connective tissue or collagen fibers, and the red color would show us the blood vessels. So as you can see, and as you recall from last year, granulation tissue means loose connective tissue and abundant capillaries. And this heralds the beginning of the repair phase of this condition. So we started with cell damage or necrosis, then we had 2 phases of inflammation, and then the third important process is now beginning, which is tissue repair. Tissue repair of acute myocardial infarction would always end with having a scar or connective tissue fibrosis. In this picture, as you can see, we have some loose connective tissues colored blue and a lot of blood vessels that are colored red. This tissue is weak and is not sufficient to or does not have the same strength as the original myocardium. Last phase of the microscopic evolution of myocardial infarction and its repair is the development of a dense collagenous scar. Again, this stain is Masson trichrome stain. The blue color is the scar that has developed inside the necrotic area of the myocardium. The red tissue here, as you can see, is the remaining viable myocardial cells. This phase happens several weeks after the onset of the myocardial infarction. So at least 6 weeks maybe are needed to develop a dense and a strong scar that replaces the non-viable myocardium. Although this tissue is strong, but it's not quite strong as the original myocardial muscles, it does not have the same contractile ability as the myocardial muscles, so it will always be abnormal. Now, what are the consequences and complications of acute myocardial infarction? The most important and the most feared complication is, of course, death. 50% of all deaths following acute myocardial infarction develop before reaching the medical care. This means that this death happens within maybe 1 hour of symptom onset. And the cause is usually a lethal arrhythmia. And this will be defined later in this lecture as sudden cardiac death. These arrhythmias are caused by electrical abnormalities that involve either the ischemic myocardium or the conduction system itself. Thanks to the current medical care we have nowadays, patient outcome is much better. So in hospital, death rate has declined. This is an example of a lethal arrhythmia that usually leads to death following acute myocardial infarction. It's called ventricular fibrillation. So there's an abnormally fast and chaotic heart rate, and the ventricles actually quiver rather than beat appropriately. Other complications and consequences of myocardial infarct includes cardiogenic shock. As we said before, this happens with very large infarcts that involve more than 40% of the left ventricle. This will lead to pump failure in the heart and consequently development of cardiogenic shock. This condition is very significant and very dangerous. It can have a very high mortality rate and is an important cause of in-hospital death. The third consequence of myocardial infarction is acute myocardial rupture. And the consequences of this condition depends on where exactly the rupture has developed. So if the rupture happens in the free ventricular wall, it will lead to hemopericardium and cardiac tamponade, which is usually fatal. If the rupture develops within the ventricular septum, this might lead to ventricular septal defect, VSD, and left to right shunt. If the rupture develops in the papillary muscles that surrounds the valve, for example, this will lead to valve abnormalities like severe mitral regurgitation. Fourth complication, pericarditis. This is usually an immunologic condition that develops 2 to 3 days following a transmural myocardial infarct. It usually resolves spontaneously. Infarct expansion means disproportionate stretching, thinning, and dilation of the infarct region. Mural thrombus, as we said before, when we discussed the subject of thrombosis, we said that a major factor in virtuous triad is stasis. So the loss of contractility inside the damaged chamber would lead to stasis, and the endocardial damage that is associated also with ischemia will all lead to thromboembolism. The seventh complication is called ventricular aneurysm. This is actually a late complication that needs several weeks to happen because it needs to have a scar tissue in order to develop. This is usually seen with large transmural anteroseptal infarcts that heals with the formation of a very thin scar tissue. So as you can see, this tissue here with the red arrow has a very thin scar tissue in comparison with the remaining viable myocardium in the upper parts of the picture. So this thin scar is very weak. It cannot have good contractile capacity like the viable myocardium, and so this area is prone to develop aneurysm, which means abnormal and permanent dilatation, especially during the cardiac contraction, during systole. Now, potential complications of a ventricular aneurysm might include the development of a mural thrombus inside the affected chamber, development of arrhythmias because this scar would also have abnormal conduction process inside it, and heart failure, of course. Long-term prognosis following MI depends on many factors. For example, the remaining left ventricular function, the severity of atherosclerosis in the remaining viable myocardium, and many other things. The highest mortality rate following acute myocardial infarction is actually during the first year following MI. After that, the annual mortality is almost constant and is much less than before. Now, moving into the third clinical syndrome of ischemic heart disease. This one is called chronic ischemic heart disease. So as you can see here in this picture, the cardiovascular disease has a continuum. It starts with maybe endothelial dysfunction, the presence of atherosclerosis, possibly hypertension and peripheral vascular disease, all of which will eventually lead to development of myocardial ischemia. The first clinical syndrome of myocardial ischemia, as we discussed before, is angina, and then with more and more ischemia, there will be myocardial infarction, which was the main subject of this lecture. Now, following acute myocardial infarction, in the patients who survive, there will be some kind of remodeling and ventricular dilatation that will eventually lead to a progressive state of heart failure. We call this chronic ischemic heart disease. So, chronic ischemic heart disease results from post-infarction cardiac decompensation that follows exhaustion of the hypertrophic viable myocardium. This progressive heart failure is sometimes punctuated by episodes of angina or another MI, and arrhythmias of less significance can also develop, and they are quite common during this phase of ischemic heart disease. The fourth and last clinical syndrome of ischemic heart disease is called sudden cardiac death. This condition is defined as unexpected death from cardiac causes, either without symptoms or within a short period of symptom onset, less than 24 hours of symptom onset. Atherosclerosis is still the most common and the most important underlying cause of sudden cardiac death. The direct mechanism of death, however, is related to lethal arrhythmias, especially ventricular fibrillation. With younger victims and with victims of sudden cardiac death without a significant atherosclerotic disease, other non-atherosclerotic causes are more likely to be seen. So this list includes some non-atherosclerotic causes of sudden cardiac death. And as you can see, there are too many conditions that are beyond the scope of this lecture. These are only for you to understand and to know that there are many other things that might lead to sudden cardiac death other than atherosclerosis. These are usually seen in younger patients, possibly in athletes, or people who have certain hereditary or acquired abnormalities of either the cardiac conduction system or the cardiac muscles.